small proportion of neurologic Lyme disease, at least in our experience with North American patients, will produce oligoclonal bands which disappear after therapy, whereas MS oligoclonal bands, once they become positive, they really stay positive.
And you can say with absolute accuracy that doesn't happen.
Well, you know, nothing in life is 100%, but I can generally come to a resolution where I can tell the patient I'm, 99% certain this is what I think you have, but I will never say 100% ever.
May I add to this one question? Have you tested large numbers of sera or CSF from these MS patients?
Yes, a good proportion of the ONDs there. See, we do a lot of spinal taps, and the other big disease group that I see is MS. So many of those OND spinal fluid samples are MS samples.
Yes, but do you find more PCR positives in MS patients?
Well, let me tell you that the PCR yield, it depends on the assay. No.
Last question, please.
I was wondering if one of the speakers, starting with Pat Coyle, maybe going to the others, would talk about the usefulness of these tests for patients who have persistent Lyme encephalopathy.
I think some of these tests are very, very useful. The data that I presented is obviously on pristine, pure CDC cases, because I think if you're talking about trying to really validate assays, you have to start with kind of cases that no one questions, but then hopefully the data, the information learned from that can then be applied, and I can tell you in our experience that yes, these assays are very helpful.
Do you have any results you want to share on patients with Lyme encephalopathy who
no, that would probably be a talk in and of itself.
Okay, thanks.
If there are no more questions, I would like to thank the speakers. And sorry, make a comment.
I'm here as a watchdog, but I'd like to ask Dr. Schützer. The data which you have shown and which you have published recently is mostly for the early infection, and I think we need the active markers of the infection, especially for the late infection, because that's where the most dilemma is. Do you have any comment on how the immune complexes are working, performing for the late infection?
Yeah, actually we're finding basically the same thing. So what I presented really applies also to the late, and it has more emphasis. I think 2 years ago we never thought that you'd find OspA antibody in the first week of infection, but clearly we can. And some of the data may show, if you use a more conventional assay, that there's a switch from OspA. Maybe it appears early. I mean, other investigators have reported seeing early appearance of OspA, and also in animal models, and that may wane, and an OspC comes up right away, and that's what seems to be there. And then by using conventional assays, you'll still see OspA persisting. So, sort of answer your question, I think these apply equally to early or late.
Okay, thank you very much.
I have a couple of announcements to poster session.
Plasmacellular infiltrate. On day 20, while this rash was still apparent, this patient developed a transient atrial fibrillation. He had absolutely no known risk factors. He could have been the only patient in my practice that, other than being a male, had no known risk factors. No family history. His cholesterol was low. His iron was low. He didn't smoke. He didn't drink. He exercised regularly, and absolutely no risk factors whatsoever. With a 2-year follow-up, he's had no further problems. His echo was normal, the whole 9 yards. And this is in his biopsy. Another Dieterle stain, courtesy of Dr. Dre at Harvard. A fairly large one that had multiple lesions with it on the other side. Another young turkey hunter, and on the other side of his foot he has another rash. This is our sentinel case, so to speak. She had a tick bite right there. 9 days later, noticed a rash which spread to this. This is her pathology, again showing the lymphoplasma cellular infiltrate or perivascular infiltrate. And what makes this case interesting is that we decided to focus on this young girl's farm, and Dr. Oliver and his postdoc, Dr. Tom Kohlers, went out there and did some epidemiology work by trapping animals and tick collecting and so forth. And we now have not 3 but 4 isolates of atypical B. burgdorferi from identatus ticks on this girl's farm. And these have been characterized, and they are indeed B. burgdorferi, but they're unlike B. burgdorferi that have been previously reported in North America. Now, whether they are involved in that girl's rash, we don't know. But the fact is, she has B. burgdorferi on her farm. She had a tick bite. She developed an EM rash, which fits diagnostic criteria by any standard. Our rashes occur just like they do nationally, summer months. My particular approach to this is with an EM rash, I try and encourage the patients to save the tick, test the tick if it's alive, measure the rash, photograph the rash, especially if they can't get into their doctor right away. And then on the initial visit, I usually don't do a serology. I will save the serum and urine and freeze it. And then on a follow-up visit 3 to 6 weeks later, I will then do the serology. The yield seems to be higher, although we get irregular results. Well, in my opinion, the most effective clinical instrument used in documenting early Lyme disease is your camera. And the reason for that is the least controversial aspect of Lyme disease is the rash. And this photograph is, I'm sure most of you would agree, is far more convincing than any test I can get short of a culture. And I think we need to document these, measure, and supposedly the diagnosis of Lyme disease is a clinical one. That's what the CDC says. That's what all the literature says. In reality, it's a clinical diagnosis until you make it. And then you better have documentation. And that's why I encourage you to document ad nauseum, especially with your camera, and save sera when possible. If it's not Lyme, we need to know what it is. Well, quickly, tick bite or spider bite, this often gets confused. Cutaneous loxoscelism versus erythema migrans. In the literature, they are both described as having a bullseye appearance. That's a brown recluse spider, sometimes called a fiddleback, with a violin on the dorsum. It's usually the extent of the legs will extend to about the size of a quarter. This is a classical brown recluse spider bite. Now, with a brown recluse, the punctum, or the actual bite site, is almost always eccentric. It's not in the center. It will be at the edge of the area of impending necrosis, if there is impending necrosis. And the necrosis, which I've never seen in a tick bite, but I know it occurs, but the pictures I've seen are usually symmetrical. The necrosis with the brown recluse spider bite is very irregular and shaggy. Then you get an area of redness, erythema, ischemia, and then the necrosis. And then you also get a rash that tends to be gravity dependent. It will sort of go with the flow. That's not unique to spider bites, but when you get several of these things together, then you can conclude clinically that the likelihood of this being a tick bite is very, very low. Also with spider bites, they hurt, and the pain can be completely disproportionate to what you see. Spider bite patients that go to the doctor usually hurt like heck. I have never given an analgesic to a rash following a tick bite. I have never not given in my office an analgesic to a spider bite victim. So if you have this red, white, and blue sign, pain, and gravity-dependent erythema, in my opinion, or at least I personally do not order Lyme serologies because it's a spider bite. Here you have the erythema, ischemia, necrosis, irregular punctum, gravity-dependent erythema. This patient required morphine. He was in so much pain. Just to show you what a spider bite can do, it takes weeks and weeks and weeks, and they don't often start out like that. Here's a bad one here with this eschar. This is like 2 months later with this huge area of tissue necrosis. On day 2, that could have almost looked like an early erythema migrans. So you want to be careful about telling people, it's no big deal, it'll go away, don't worry about it. If they end up with something like this, you're not going to have a happy camper. Okay, signs and symptoms. We looked at this extensively. This was published in the March issue last year of the journal, the Spirochetal and Tick-Borne Diseases, and we compared physician-diagnosed erythema migrans that met CDC criteria in Missouri, 600 and some odd cases, and the signs and symptoms pretty well mirror what was reported nationally for the same time period. Not a big difference. Completely consistent with the spirochetal illness. We do see arthritis. Here's a deer hunter with a very convincing Western blot and negative workup for other things. 2 days later, he had a swollen wrist, migratory. Young boy with an intensive tick exposure, swollen knee, won't walk. He had, in addition to other bands, a 31 and 34 in tandem on his Western blot. We also see it in animals. This dog tested positive by Dr. Bosler at Stony Brook. Bell's palsies we see. This is this guy's third Bell's palsy. He had one on the right, then the left, and then the right again. And here's another Bell's palsy in a dog. This was at the site of a farm that was a survey site for a tick survey where positive ticks were found by Dr. Fear. And the dog continually drools out the right side of the mouth. Here the dog's trying to growl at me and the nose is all scrunched over to one side. And we tested this dog and it tested positive, not once but twice, and had a rather dramatic response to antibiotics, which as an astute clinician, I really pounced on the diagnosis, and this was obvious canine Lyme hysteria. So we immediately searched the dog pen for urine-soaked newspaper articles about Lyme disease that would influence his behavior, but he had already gotten rid of them. And we just then concluded this is further evidence of the placebo effect of antibiotics in canine Lyme hysteria. And just to show that we too get permissions, consent forms. Third nerve palsy. That's not a diabetic third. This guy received exhaustive workups and responded dramatically to antibiotics and had a positive Western blot. Unimpressive rash, KLH negative, deer hunter, fell out of a stand, flu-like illness, had these things in his blood. Unfortunately, the culture died, but not before we got to photograph it and test it. It was P. burgdorferi. Helpful history, obviously a history of erythema migrans, defined onset, multi-system, cyclic, and sorry about the misspelling, but one that I want to point out that is really helpful for me is prior good health. As a family doc for 24 years, I have certainly seen my share of hypochondriacs, or crocky patients as it were, and by and large, they have one thing in common. They've always been crocky. They have always been that way. Within 3 office visits, everybody from the receptionist to the lab tech knows who they are. And these stand in stark contrast to the patients who lead a normal life, go to the doctor once a year, and then suddenly they're sick as heck with a multi-system illness that we can't figure out what's going on. Just because we can't figure it out doesn't mean they're not ill. And to my knowledge, hypochondriasis does not arise de novo in a middle-aged patient with no identifiable external stressors. I just don't have any that got their hypochondriasis Labor Day weekend of 1993. And just to show you, to put a face on this like Dr. Ligner did, this is my favorite case. This is Renee. Renee is a developmentally retarded 3-year-old. She's one of these kids that you see across the room and it breaks your heart. She just sort of stands and drools. She tested out at the 11-month level. In reviewing her previous doctor's charts, product of a normal pregnancy, labor, and delivery, in his records, she was treated with 5 days of ilosone, which is an erythromycin, for a cellulitis following a tick bite on her abdomen at age 5 months. She was continually ill since then and did not develop. She had these constant little circular rashes that would come and go, which may or may not have been a secondary rash of Lyme disease. We don't know. We worked her up for everything under the sun, from toxic metals, lumbar puncture, MRI. Let's find something we can do something about. The only thing positive was her Lyme serologies. She had an ELISA over 5,000. She had positive Western blots ×2. We treated her with antibiotics, and in my 24 years, it was the closest thing to a miracle I've ever seen. And 1 year later, the lights are on again, and she tests out at 3 years and 9 months. She's almost caught up. Now, she's not completely normal, but she isn't going to be institutionalized either. And how many other Renees are out there? Now, you ask this mother, well, was that typical B31 beryllium, or was that B. burgdorferi's long-lost identical twin separated at birth, never heretofore heard from? Do you think she cares? I treated something, and it made this child's life livable. Well, new opinions are always suspected and usually opposed without any other reason but because they are not already common. John Locke, pertinent quote for this conference, and from my favorite philosopher, Yogi Berra, the future ain't what it used to be.
Thank you, Dr. Masters. The way the program priced from the Centers for Disease Control here in Vancouver, and he's going to describe Lyme arthritis in British Columbia.
Thank you, Mr. Chairman, and thank you to the Lyme Disease Foundation for the opportunity to make this presentation. Peripheral arthritis, as you all know, was the presenting feature in the first cases of Lyme disease that were reported by Steer and his group in 1977. Arthritis continues to be one of the prominent late manifestations of Lyme borreliosis infection. But to date has not been recognized in British Columbia, despite unequivocal evidence that there are ticks infected with B. burgdorferi present in many areas of the province. Today I would like to convince you that the possibility of Lyme arthritis must be considered in British Columbia patients presenting with recurrent and chronic arthritis. This case is Mr. H.P.J., who happened to be a personal friend of mine who rarely came to the doctor. But he presented to me a while ago with pain and swelling in the left knee, and on questioning admitted he had felt vaguely unwell for an indefinite time. He gave a 6 months history of recurrent pains in the knees with swelling on one side, pains in the shoulders, and pain and swelling of multiple finger joints. He had treated himself with an anti-inflammatory agent, but as it usually does, it caused gastrointestinal upset, so he stopped it. He then took devil's claw root, and finally, in absolute desperation, gave up his jogging. But the problems recurred. 1 month prior to presentation, he spent 4 days in bed with pain and swelling of the left knee and pain of the lower thigh. Although this improved him, he continued to have a lot of trouble. He had a long-standing and remote history of back trouble, which had resolved with surgery. He had never had previous peripheral joint problems, and there was no family history of psoriasis or arthritis. On system review, there were no systemic complaints of note. In particular, he had had no recent travel outside the country, no recent gastrointestinal or genitourinary symptoms, and no neurologic symptoms. This patient was retired and lived on a small island between Vancouver Island and the mainland of the province, approximately 100 miles north of Vancouver. He tended to live an outdoors existence there and was very active, having run marathons in the past. He was an avid deer hunter on the island where he lived, and every fall he described having frequent exposure to deer ticks, but he did not recall actual tick bites or rashes. He had also been potentially exposed to ticks in the eastern area of the province where he had packed an elk out of the bush some 3 years earlier, but he had not got sick after that. On examination, his vital signs were stable, general examination unremarkable, and the positive findings were confined to the musculoskeletal system. There he had swelling and tenderness of the right wrist. He had slight swelling of the left wrist. The right second MCP joint, the knuckle joint, was swollen and tender. The left knee had a small effusion and was painful on movement. He also had tenderness of the joints of the right foot. His back and neck movements were full and pain-free, and chest expansion was normal. At that time, the diagnosis was inflammatory arthritis of unknown type, and laboratory studies were instituted. The pertinent studies are mentioned on there. The hematology was normal. His sedimentation rate was clearly elevated at 37 millimeters. The serology for connective tissue disease were negative. Serum proteins were normal, chemistry normal, hepatitis serology normal, and T. pallidum test non-reactive. His radiograph showed an interesting finding in that the radiologist independently reported that there was poor definition of the right patellar and quadriceps tendons. This is a manifestation of edema of these tendons and is typical of involvement of Lyme arthritis, a condition called enthesopathy or enthesitis. Lyme serology was performed. His Lyme serology showed that the enzyme immunoassay was reactive and the confirmatory Western blot for IgM was reactive with 4 significant bands, and it was reactive for IgG with 9 bands from 17 to 97 kD. I saw him a week later after the investigations were returned, and at that time he had developed increased pain and swelling of the left knee, and new swelling and tenderness of several joints in the right hand, as well as the other problem with the right wrist. The presumptive diagnosis of Lyme arthritis was made and was started on oral doxycycline, 100 milligrams twice a day for 1 month. He quickly improved, and within 2 weeks he said he felt better than he had for a long time, and he realized that he had been sick for longer than he thought. 2 years later, he remains perfectly well. He's had no recurrence whatsoever of arthritis. His most recent sedimentation rate was 2 millimeters, and a repeat Western blot assay has showed that the IgM reactivity has vanished, the IgG reactivity remains. Just a word about the arthritis of Lyme disease. This occurs at a mean of 6 months after the primary infection has occurred. It usually starts as recurrent arthralgias and musculoskeletal pains, which are followed by intermittent episodes of arthritis with a predilection for the larger weight-bearing joints, particularly the knee. Periarticular structures such as tendon and ligament attachments, the entheses, may be involved, and as I mentioned, this can produce characteristic radiographic findings, as was noted. Attacks of arthritis usually remit in a few weeks, but tend to last longer as the disease progresses. Approximately 10% of patients with Lyme arthritis may go on to develop chronic inflammation and even some joint erosions, which can resemble rheumatoid arthritis. Using currently recommended antibiotic treatment regimes, the arthritis can usually be cured in most cases. Early recognition and treatment, therefore, can prevent permanent joint damage. Thus, Lyme arthritis is a potentially curable cause of chronic arthritis if detected early and treated appropriately. Treatment failures may occur for reasons that aren't clear at this time, but as we learn more about the bacteria and as we learn more about treatment regimes, this may not always be the case. In summary, then, this patient presented today had a clinical presentation and course compatible with Lyme arthritis. In the laboratory, his serum demonstrated positive IgM and IgG Western blot criteria for an infection, and he responded promptly and completely to antibiotic treatment. Now, as you heard yesterday from Dr. Banerjee, B-Burgdorferi has been isolated from at least 2 varieties of ticks and from rodents in many areas of this province. In the case described today, the infection was probably acquired on the coastal island where he lived and where he had frequent exposures to ticks. Dr. Banerjee's team has found spirochetes in 2 areas close to this subject's island of residence, so the infection is probably established where he lives. Current Canadian surveillance definitions for a confirmed case of Lyme disease are listed here. History of an exposure in an endemic area and either erythema migrans or a clinically compatible late manifestation and laboratory evidence comprise a confirmed case. I would submit to you that British Columbia must now be considered an endemic area and that this individual therefore would meet the criteria for a confirmed case. The criteria for a probable case are less rigid, as you might expect, but a history of exposure in an endemic area and recognition of EM, or both of the following, a clinically compatible late manifestation and laboratory evidence of B-Burgdorferi infection, comprise a probable case, and this gentleman clearly achieved those criteria. Can I have the lights up, please? I'd like to make a few comments about Lyme arthritis in British Columbia. In In this province, there are a large number of people who enter wild areas in the course of work or play. There are many small towns in the province which are rich in wildlife around the region, and the major source of revenue is tied to resource industries such as logging, mining exploration, and the like. Participation in a variety of wilderness recreation activities such as hunting, hiking, lake and stream fishing is a way of life for many people in this province. Thus, there is a substantial section of the population who may be exposed to ticks infected with B. burgdorferi, and tick bites are commonly seen here. Despite this potential, it is strange that locally acquired Lyme disease is so uncommon, and in particular that Lyme arthritis, to my knowledge, had not been previously recognized in the province. In a prospective study in 1987, Steer et al. Found that 61% of patients with untreated Lyme disease developed one or more episodes of arthritis lasting less than 1 year, and 11% developed chronic synovitis. Since the population of this province exceeds 3.5 million people, we would have expected to find many cases of Lyme arthritis identified. As a matter of history in this province, the rheumatology physician network is highly organized, and there is a substantial number of highly trained practicing rheumatologists throughout the province. In addition, in areas that don't have rheumatologists, there is a well-developed traveling consultation service where rheumatologists visit remote areas and consult on patients with rheumatic problems on a regular basis. These rheumatologists are all aware of the diagnosis, and yet to date have not identified the condition in patients. We have to ask, why is this so? It is known that the incidence of arthritis and Lyme disease varies from country to country for reasons which are not clear. As noted earlier, it's common in the United States, but it is less common in continental Europe, and in the United Kingdom probably is less than 10% of infections. Thus, there may be some unknown geographic factor which accounts for the lack of identified cases here. However, it may be that testing for Lyme disease by our doctors has not been extensive enough, so cases are being missed. Against this is the fact that Dr. Banerjee, in cooperation with the Pediatric Rheumatology Group in Vancouver, conducted a seroprevalence survey of Borrelia exposure in 172 children with chronic arthritis in BC compared to 52 non-rheumatic disease controls. They found no significant differences in the distribution of antibody titers to 2 spirochetes between the two groups. When they did immunoblot studies on those with elevated titers, the results were very nonspecific. These results suggested that, at least in the children of BC, unrecognized Borrelia infection is not the reason for the lack of identified cases of Lyme arthritis. Therefore, perhaps there are other factors involved, such as a lesser degree of virulence of the organism or a less favorable environment for the propagation and transmission of the organism in the various hosts involved in the life cycle. In any case, the reason why this sequela of Lyme disease is unusual here is unexplained and must be further investigated. We need some serologic surveys of an adult population with chronic arthritis with appropriate controls, and we need more frequent testing of adults who have a recent onset of compatible arthritis. I'm sure more cases will be identified. If arthritis due to B. burgdorferi exposure is present, it must be found and treated, as the costs of untreated acute and chronic arthritis to the individual and to society are substantial. Thank you for your attention.
Our next speaker is Dr. McManus. He is Chairman and Chief of the Department of Pathology at the University of British Columbia, and he's a cardiovascular researcher.
Of heart and blood vessels, and one of our main focuses in the laboratory is the study of enteroviral infections of the heart, acute and chronic infections, and the relationship between acute injury and chronic cardiomyopathy. And I'll come back to that issue in the discussion regarding Lyme disease. We've also been interested in the pathogenesis of rheumatic heart disease, and since it's been one of the mimics or lookalikes for this condition, it's perhaps relevant that I'm here. Also, when I was a little boy and I was doing my residency in Boston, I had the privilege of having one of my professors be Gustav Damon, and I was there just at the time, I believe, that they identified the Ixodes damani tick as the vector for this disease. Now, you know very well, perhaps better than I, that in the second stage, is presented in the middle of this slide, if I could have that pointer, as presented here in the center of this slide, that in addition to neurological complications and migratory musculoskeletal disease, cardiac difficulties may present, and this may affect estimates of 5 to 10% of patients and lasting anywhere from a few days to multiple weeks. The typical clinical presentations are palpitations, dizziness, and shortness of breath, although syncope is also described in those patients who have complete heart block. And various degrees of incomplete and complete heart block are the main manifestation, as well as histopathological myocarditis, and on occasion, as I'll show you, reports of actual congestive heart failure. And we'll talk about the therapy of these conditions briefly. Just a brief synopsis of what's been written about the cardiac manifestations of this condition. Alan Steer and his group from New Haven wrote still one of the best papers that's available on this when he described 20 patients that he had observed through the previous decade. And in this description included electrophysiological, clinical, and serological information. It was the first North American description of carditis, although people certainly had observed it before this time. Then there were cases described from Australia, from Europe, and folks began to do specific investigations concerning the electrophysiological abnormalities and demonstrate, using endomyocardial biopsies, inflammation and spirochetes in the tissues of the heart. Hugh McAllister, an excellent pathologist in Texas, working with some folks in New York, did a general overview of 54 cases, reviewing literature and their own experience in 4 patients of cardiac disease in 1990. And then Vanderlind did a nice synopsis and comparison of complete different kinds of heart block in North American and European cases. And I'll try to show you some of the highlights of this. In summary of McAllister's paper, kind of a reductase version, you can see that from 1977 to 87 in 22 studies, there are 54 patients synopsized. Mean age of these patients was 34 years, mostly males, more than females, and the mean duration post-rash was 31 days, and the mean duration of the resolution of cardiac symptoms was 27 days, so it's about 30 and 30 if you want to remember those numbers. Atrioventricular block was seen in 15 patients, Wenckebach block, suprahis, an infrahis block in 8 patients. Complete heart block was described in 16. Different investigators describe these as differently, so they're probably very similar, but have been used different terminology. And various alternating left and right bundle branch blocks and intermittent bundle branch blocks with complete block were also seen, as well as a rare sinoatrial block. The clinical correlates of that included murmurs, enlargement of the heart, gallops, third heart sounds, one report of a positive gallium scan showing inflammation within the heart in 1985, as well as pericardial effusions representing the fact that this is a pancarditis, much like acute rheumatic carditis, as well as occasional supraventricular tachycardias, and like Dr. Masters referred to, an occasional rare patient with atrial fibrillation is the main electrocardiographic manifestation, and an occasional patient with sudden death. The treatments are listed here that people have utilized, but I emphasize only the pacemaker business, which I'll talk about in a moment. In 1980, Alan Steer I always thought that people who are interested in electrophysiology had to be from another planet. So I won't spend too much time on this slide, except that this is a lead 1 electrocardiogram, and then this is a His bundle electrocardiogram here, HBE. And the main point is that here and over here, the first beat and the fourth beat are escape beats, and here are 2 normal beats. And the point is that you have an A to H interval here and then a V wave on the electrogram, and over here you have an A to V, but you don't have the His electrogram doesn't show up when you have the escape beat. But the other feature here is that they have marked prolongation, 300 milliseconds from A to H, indicating the degree of block present in these patients. They also observed that the duration of heart involvement in weeks, looking anecdotally, this is not a controlled study, this was just a synopsis of their patients, looking at prednisone versus aspirin and no treatment was basically no difference in a rather small group of patients, kind of thrown off by the one patient up here who didn't respond to prednisone. Otherwise, you might have thought that anti-inflammatories would have been useful. A similar type of recording by Hugh McAllister's group in 1989 shows a 6-second pause of ventricular activation from here to here with ongoing atrial beats indicated by the arrows and a slightly prolonged QRS complex. In 1991, you could focus that maybe a small bit. In 1991, I think Vanderlyn did a nice job in summarizing what's known and showing you the universality between U.S. and Europe as far as the commonness of third-degree block. It's really common. It's by far the most common of the manifestations that are seen clinically. That partly may be the fact that the first and second-degree blocks simply aren't so clinically visible, therefore aren't identified and aren't picked up. And certainly third-degree block is a much more clinically visible event. But there's an interesting comparability between these 2 sets of data. I wanted to make a comment about the case report by Marcus against Steer's group in 1985 that you are all probably fully aware of, fatal pancarditis with coexistent Lyme disease and babesiosis. It was a 66-year-old man with a febrile illness, and he had concurrent infection with Babesia microti and no clinical heart disease. At the time he was first identified as having Lyme disease, he received chloroquine for the Babesia that were seen within red cells, and in hospital had an unwitnessed presumed sudden death. At autopsy, the heart was a bit enlarged, felt to be moderate left ventricular hypertrophy. There was a pancarditis involving the myocardium, the endocardium, and the pericardium, and the spirochete was found within the interstitium. And this is the picture from their paper showing this mixed mononuclear cell infiltrate and an edematous appearance, generally the myocytes intact. And they demonstrated with the Dieterle stain the presence in the myocardium here and the myocytes, as well as in the blood vessels, the organism. Resnick, the year following, showed a similar biopsy sample from the heart in a living patient with a perivascular lymphoid infiltrate and the Dieterle stain demonstrating the organism within the myocardium itself. There was a scan in that paper, a gallium scan, demonstrating a high uptake in the region of the heart, the liver being over here with a capital L. And in 1990, Stanek really carried the discussion, I think, to where it is today. And perhaps of the 2 main points I want to leave with you when I end this discussion is the question of whether there is a chronic immune or even chronic persistent Lyme infection that might involve like the joints and or the myocardium. And this is a Dieterle stain and a nice color picture from the New England Journal showing the organism within a myocyte in the heart of a patient. And they also were able to culture the organism out and demonstrate from wild type in this western lane over here, some changes change in expression of some of the proteins, the loss of the 31, 34, and the 20 kilodalton, and a new band here, but basically corresponding pattern to the wild type, demonstrating the organism is some type of Borrelia. So in synopsis of Lyme carditis, these are the main points. It is unusual as a cause of potentially lethal heart block. So it's kind of this paradox. It's uncommon, but it's potentially lethal. Also, it's usually transient, as we've demonstrated. It fluctuates with other less impressive conduction disorders. It is usually accompanied, and probably if we could look inside the hearts of these folks, you'd find various degrees of myopericarditis in every one of them. And ventricular dysfunction has been demonstrated in a few patients, frank ventricular dysfunction outside of arrhythmias. And prognosis is excellent after the initial episode. Early detection of the cause of these changes is critical in order to avoid the unnecessary permanent pacemaker implantation. There are only about 3 or 4 reports in the entire literature where people actually put in a permanent pacemaker, and that was only when they didn't recognize that this was Lyme disease. Otherwise, they should have a temporary pacemaker, and the patients will do very, very well. Certainly, I think acutely ill patients would warrant having an endomyocardial biopsy. I find this interesting. I'd be interested to hear what the audience would say about the propensity of males versus females, and whether this is just that there are more male hunters and hikers and wilderness people. And finally, the incidence is likely to increase, especially in the endemic areas, and the cardiac findings may become more visible. I'd like to thank Shalina Babul, and thank you for your attention. We have about 15 minutes for discussion, and perhaps you may have questions for Dr. Masters, Dr. Price, or even myself. Or are we finished? We have 5 minutes. So we have time for just a few questions or comments. Dr. Masters, I wanted to ask you something, because I'm a naive guy, I didn't see any of your pictures of your patients that had multiple skin lesions, and the little reading I've done, and since I'm not a skin guy, suggests that this is the case. How often do you see that?
17%. That compared with the published studies by Maserati of 18% in the others. Actually, I did show 2. A large one on the belly and 2 on the other thigh in the young turkey hunter with the back of his leg, and the second lesion by the small toe. But over a fairly large number, the incidence of multiple lesions was 17%. We've tried to characterize these every which way but up, and really trying to find if there's a clinical way to distinguish these from incubation time, appearance, size, characteristics, histopathology, and we haven't found it.
I have a comment for Dr. McManus. I'm Dr. John Drill from New Jersey. Everyone's familiar with the descriptions in the literature of the heart manifestations of stage 2 Lyme. I don't recall reading anything about what happens in chronic or third stage Lyme. Having dealt with Lyme patients for over 10 years, I've made several striking observations of what people with chronic Lyme complain of as far as their heart's concerned. Many of them have nonspecific chest pain, precordial, often radiating to the left shoulder of the arm. They frequently end up in the emergency room, worked up for a possible MI. Results are negative. They often have palpitations of a nonspecific nature. They're very annoying. They've never had them prior to Lyme. Holter monitors, again, are nonspecific, just may show runs of rapid heartbeats. Occasionally we've seen patients who develop bigeminy in late-stage Lyme, which miraculously resolves with antibiotic therapy. Another interesting observation I've made in probably several dozen patients is a persisting rapid heart rate, well over 120 or 130. Interestingly, it doesn't respond to vagal maneuvers, suggesting possible vagal nerve dysfunction. But it may also, on top of that, be prone to episodes of tachycardia, palpitations, heart rates going up to 150, perhaps initiated by sympathetic nervous system dysfunction, because there may be episodes of flushing occurred along with that. They've been worked up for carcinoid, et cetera, and been found to be negative. Interestingly, when we treat these patients with antibiotics, we can see that over time their resting heart rates slowly normalize over a number of months. Just want to know if you have any comments on my observations.
Well, I think you have so many observations that you should publish them. I mean that seriously, because the paper by Stanek, as you is the only one that, well, it does two things. It was 3 years after presumably it was 3 years after the only and the actual tick bite and the infection that the observation was made that the organism was in the myocardium, and also that the patient had abnormalities of ventricular function. And I think that the question as to whether there is a chronic component to the cardiac disease is not very clearly addressed in any of the publications so far, and people have focused on the acute disease. So if you have that experience, I guess my response would be it should be published if it could be documented. Any other comments before we, yes, sir? Yes, sir.
Can you hear me? Okay. I'm Richard Furr from Ocean Springs, Mississippi, in family practice and internal medicine. I'd like to ask Dr. Masters, do the authorities in your state still deny that you have Lyme disease in your state?
Well, we have something. Clinically, it's Lyme disease. We have not fulfilled Koch's postulates. We do not have a living, viable isolate out of a human being. I've mentioned this to others. If they said, gosh, Ed, what do you have there? Do you have typical Lyme? Do you have atypical Lyme? Or do you maybe even have something else mixed in? My honest answer would probably be all of the above. It's an evolving situation. It's very unclear. And it needs more study, desperately. You know, these rashes don't arise de novo. I don't have a tattoo parlor in the back of my office, and I don't make these people walk in with this. I just report what I see, and I know what I see. I've been doing it a long time, and it just is what it is. And it needs to be characterized. Now, clinically, it's indistinguishable from Lyme disease. Dr. Barber indicated that maybe there's another, as yet, uncharacterized spirochete in Lone Star ticks that could mix in with some of the atypical Borrelia that Dr. Oliver has cultured, and I think that's a real possibility. In the meantime, I've got a patient sitting in front of me that's sicker than heck, and what am I supposed to do with him? And that's what I've been pleading with for a long time, is if it looks like a duck, walks like a duck, quacks like a duck, for the time being, I'm going to treat it like a duck. And ironically, these patients respond. And to me, that's the bottom line. I really think this deserves a lot more study, because I don't think this is unique to Southeast Missouri. 6 years ago, if somebody had asked me, do you see any erythema migrans in your practice? I would have said no. I don't see any erythema migrans. And then patients learn to come in. Erythema migrans usually doesn't hurt. The patients often aren't sick. It's not painless. It's on an unexposed area of the body very, very often. And if my rural patients ran to the doctor every time they had a little area of red skin, A, they wouldn't get any work done, and B, they would be broke. They have to know to come in. The first 25 patients I had with erythema migrans, I asked them, or what I thought was erythema migrans, I asked them point blank, 2 years ago, would you have come to the doctor with this rash? 24 of the 25 said unequivocally no, and the other one said, I don't know, maybe, maybe not. So most of the patients that I see, if I ask them, why are you here? Well, because my wife saw a picture in some magazine and she thinks that this might be serious and she made me come, or something like that. It's knowledge that brings them to the doctor's office, not pain, not discomfort. And so when these people say, well, there is no erythema migrans in my practice or in my area of the woods, all I have to say is, I would have said that too, and I was wrong.
One other question. There seems to be a problem of mostly ignorance among the physicians, because as I talked to a lady here with the foundation in British Columbia, she tells me that she carried a picture from Time magazine of her erythema migrans to her doctor and said, no, we don't have Lyme disease here. And she had that. This was in British Columbia. I'm just saying that this is a problem that's apparently throughout the world, that doctors tend to deny the presence of Lyme disease. I don't know why that is.
As late as last year in my area, a lady took her child with a good erythema migrans rash to the doctor with the tick. The doctor made a ceremony of disposing the tick in the wastebasket and proceeded to lecture her for 10 minutes how he was sick and tired of all this Lyme hysteria. And we need knowledge and we need research. And at least in Missouri, because of the controversy, it's going to become non-existent. I know my physician friends are not reporting it, and they're not going to report it. They don't have time for the controversy. They don't want to be caught in the crosshairs. And their response is, I say, well, but Lyme's reportable. We need the research. And I say, I don't have time to battle this. And besides, how can you get in trouble for not reporting something that officially doesn't exist? So if you think you're going to track this, and you're going to make a law that says if this patient meets these criteria, you have to call it this, and you must report it, and then you're going to impugn that physician's character or diagnostic ability when he does exactly what he's required by law to do. Physicians aren't that stupid, folks.
Hello. I think we should move forward with our second three presentations in this session. The next presentation is by Dr. Murakami with his colleagues Shogamiya and Dr. Banerjee from the Provincial Laboratory and Department of Family Practice here in Vancouver, and they're going to present information on Lyme disease in the Lower Mainland and a new wood tick removal technique.
Thank you very much. I'd like to thank Nima Surjanya. He's a medical student that worked with me on this project, and Dr. Banerjee, who was strength that I couldn't describe in supporting me through the whole project and continuing projects. I must say to the speaker over here that I was a skeptic until I actually came across a case. And if I could have the first slide, please. This button. The case, I thought I was being kind of unique because I'd never seen a case, but I found that there was, my case is right at the bottom. It's right at the bottom. This patient came to me with symptoms of arthralgia. He never mentioned the rash at all, but when we examined him, we found a circular rash. You can see the rash on the right leg, quite circular, and the diagnosis was made a little easier because there was a wood tick on the right leg. That spot there was a spot where the wood tick was, and it hemorrhaged a bit and left a bit of inflammation. So the whole diagnosis was easy, and I ordered blood tests for the serology. These came back positive, but in the meantime, I was convinced it was Lyme disease. Although I was a skeptic until this very day, I started him on erythromycin for 3 weeks. The rash cleared up, and because he was complaining so much primarily about his arthritis, I gave him the naproxen. But within a matter of 3 weeks, the rash was gone and his arthralgia was gone. This is another shot. This was the immunological report. You can see the ELISA test and the Western blot was positive. The IgM was negative, indicating possibly the superficial reactions were settling down at this point. My concern as a physician is that I got a bit concerned about the pamphlets that public health puts out. They say to grab the wood tick with a pair of forceps or tweezers, and you get a hold of the tick and pull it out. And my feeling for a long time has been that if you do this, you squeeze the abdomen, you project the abdominal contents and the bowel contents back into the host. So I've had some dialogue with the health people, but they won't accept this as a danger. I personally do, and I may be wrong. I'm open to discussion on that. This is the wood tick removal method recommended. We have forceps of such nature, but it usually compresses the head, crushes it, the wood tick dies, and it's no longer useful for culturing the microorganism. The method that I've been using for some time is an intradermal technique. I call it intradermal because a lot of people think it's a funny way of doing things, but I wanted to create a tremendous pressure underneath there. The logical reasoning for that is to make sure that the contents from the insect does not reverse back into the host. And if you squeeze it, it naturally does that. If you heat it with a cigarette, like a lot of loggers in our area use a match or a cigarette lighter and a cigarette to heat the back end of the wood tick. And all this does is expand the gas and liquids and project the contents back into the host. I emphasize the positive pressure because if you do that, no matter what pressure method you use after that point, you're preventing a reversal of the materials from the wood tick. Now, in 75% of cases, the wood tick will spontaneously find it's in a difficult environment. It's not tasting blood. The environment is probably cooler. There's a pressure against the mouth, and 75% will naturally drop off. And it takes a little while to get the exact spot to inject it, because if you don't, the wood tick will stay, it won't move. But if you put it in a spot where it's uncomfortable, the blood is exsanguinated or pushed away from that area, the blood will realize it's in the wrong environment. This is, again, my personal feeling. The ones that don't remove itself spontaneously, I just take a little sharp instrument like a scalpel blade, make a parallel incision, and because it's under pressure, it sort of pops open. And this allows the jaw to be easily extracted with the tip of the scalpel. Also, it allows the liquid underneath there to exude. You'll find that the xylocaine will just actually exude the material underneath the skin, which is, in my opinion, a desirable situation. I have a very good picture here, but you can see it's an intradermal test that nurses do for tuberculin testing. So it can be done not only by physicians, but it could be done by public health nurses, or nurses trained to do this, or even first aid men could be possibly trained to do this. I know they can't inject other than water, but I think even water would work fairly efficiently, but it'll be more painful. Just a side view to get the blistering effect. Now, I think if I could have the VHS picture you see over there on the right. This was I just got this last month. I've taken lots of them, but this one I think exemplified what I'm trying to portray here. It's I mentioned the intradermal method because that's what I want. is injected tightly. You can see the blood blanching out of that skin area. It goes white. And then the wood tick is sort of getting a xylocaine cocktail and not a Bloody Mary, what he wants. And you'll see just in a few minutes that the wood tick says, well, the temperature's dropped, there's no blood, there's a lot of pressure against my mouth, and up until this point I haven't touched the wood tick. The closest I've come is with that syringe. And you can see that the wood tick is a bit uncomfortable. It's starting to flail around there. I don't know if xylocaine does that to people, but it does to the wood tick. It gets quite uncomfortable. That was with epinephrine. So I don't know if that would make it distasteful or not. But it gets quite uncomfortable with it. And it takes about 30 to 90 seconds. And the wood tick just pulls itself off. And this is, to my point, from my point, a very desirable situation, since most of the time, until I practice this technique, the wood tick head and mouth would stay in the host. And then that necessitated freezing again and cutting and digging it out. You can see it squirming. It's quite uncomfortable. And it should just pull itself off. You can see it exerting a backward force. It comes off. And I haven't touched the wood tick at all. And it scampers off very briskly, and I put it inside there. You can see the wood tick there. Thank you. I took this project with my medical student. He couldn't make it today, but we both want input from you people to see what you think about this technique. I know that I have trouble convincing the public health people that this is the way to go, and the heating, the xylocaine or the acetone jelly, smothering it, I think causes defecation, urination, and vomiting. And I firmly believe that any flight or fight mechanism is the wrong thing to do, and this does not create that. If it does, you've already created a positive pressure that it can't regurgitate the contents back into the host. Thank you.
We have the microphone, please. Thank you very much. The next presentation is by Dr. Scrimente from the University of Wisconsin, and he's going to speak with us regarding Acrodermatitis chronica atropicans.
Thank you. I want to thank the Foundation for inviting me and to this lovely, lovely city, and to be able to participate in the celebration of Willie Bergdorfer's 70th birthday. Good afternoon, everybody. Our subject for today is Acrodermatitis chronica atropicans. Although ACA has been recognized in the United States almost as long as it has been known to exist in Europe, most cases are reported from Eastern, Central, and Northern Europe, especially from Sweden. Consequently, most of our knowledge comes from this rich European experience. At this time, I wish to publicly thank those many dermatologists and pathologists from Vienna, from Stockholm, and from Poland who have shared their instructive clinical cases with me so that I could make this talk possible today. Karl Herxheimer and Kuno Hartmann first distinguished two separate phases to a disease that they called Acrodermatitis chronica atropicans in 1902. They stated that the first stage was characterized by inflammation and later by atrophy. Those were the two stages. The disease was said to have an incubation period of approximately 6 months to several years, and often the disease was ushered in a rather insidious way with an angioedema type of picture. On the other hand, I think this is the most typical way that it's usually ushered in a rather acute way. I think the most characteristic thing about this is it's an acral part, and notice the distinctive discoloration. There aren't too many things in dermatology that appear that violaceous. Lichen planus is one, but the differential is not very, very great. Another thing you might notice about this is that, in contradistinction to EM, for example, this lesion is not very well circumscribed. And throughout the duration of ACA, that's another thing that characterizes it. It's not very circumscribed. Lesions can appear on the palms and soles as well as the extensor surfaces of the extremities early, and I don't know how well you can make that out, but the elbows and knees, the extensors of the extremities are the cardinal manifestations for early lesions. This is a violaceous type of eruption in a plaque over an elbow. I don't know whether you could distinguish the underlying nodule under that particular lesion, however, but I'm certain that you can distinguish these. These are fibrotic nodules that appear in a articular position over the elbows and the knees and over the small bones of the hands. They are relatively asymptomatic, and surprisingly, these respond very dramatically to oral antibiotic therapy. Fibrous bands, I don't know how well this comes through, but fibrous bands over the pretibial surfaces and the ulna of the arms also are quite characteristic in this disease, and many times they do attach to the juxta-articular subcutaneous fibrous bands, nodules that I spoke about before. The enthesopathy is common in this disease. There's a lot of tendinitis and bursitis. You can notice an inflammatory process over the Achilles tendon in this particular patient bilaterally. Sometimes, at least according to the Swedish investigators, it's a much more insidious presentation of a swelling, actually more resembling a lymphedema of the posterior aspect of the heel. My colleagues in Stockholm say this is a very, very characteristic lesion early in acrodermatitis chronica atropicans. Now, the disease, as I said, begins in the extremities and the acral parts, and then it disseminates. It disseminates centrally. And when it reaches this point on the thighs, it's probably the most characteristic. It always looks like a radiform or network-like of eruption on the thighs. Generally speaking, as it travels, it may do this in one of two ways. It may be completely coalescent down from the dorsal surface of the foot right up to the buttocks, or it can skip the dorsal surface of the foot, as it did in this case, and then creep up behind the knee and up over the buttocks or the nates. Characteristic lesion, very characteristic lesion. The Europeans tell me that ACA never progresses centrally beyond the buttocks. This is a late stage of acrodermatitis. Okay, thank you. This is a late stage of acrodermatitis characterized by a lack of edema at this particular point, but the patches are bilateral, although they're not symmetrical. You're starting to see an atrophy of skin, and you can see the architecture, the venous architecture underneath these atrophic patches very well. And in individuals who already have pre-existing varicosities, it can look quite grotesque. The skin is so thin that it often breaks down, especially over pressure points, and often leads to squamous cell carcinoma. More wrinkling over the buttocks. I also want to show you one other thing. If you'll notice, the lower half of the buttocks have a much lighter color than the superior aspect of the nates. What we're seeing here is a dyspigmentation. ACA is not only a pigmenting type of dermatosis, it may be a pigmenting dermatosis, and this is probably because of subepidermal edema. But as this becomes whiter and whiter, it can become indistinguishable from other atrophies such as lichen sclerosis, and that indistinguishable nature even holds up as far as histopathology is concerned. As the disease goes on, and chronicity, of course, is a very important feature of this disease, we notice some bony changes, as well as the dermatitis. We notice a broadening of the forefoot, for example. About 2/3 of these patients at this stage of the game develop very severe and painful sensory peripheral neuropathy. This is an X-ray photograph showing that the bony distortions are indeed subluxations of the small bones of the foot. This type of change has not been reported in the very few scanty American cases that have been reported in recent years. So there is a substantial differentiation between the European ACA and what we're seeing. This is a histopath slide showing what I consider to be characteristic of ACA. Number one, large vacuoles in the dermis. These large vacuoles are really lymphangiectatic vessels. That's what they really are. They were thought to be fatty deposits for many, many years. But these are, in fact, not deposits of fat at all. And there's a perivascular infiltrate, which is rather nonspecific, but you're lucky if you can focally find some plasma cells. That might clue you off on the etiology of this type of dermatitis. The dermatitis, very often, with the passage of time, extends right down to the sub-Q. This is a nodule that was taken off the foot approximately 7 or 8 months after therapy. We see effacement of the epidermis, and there's a loss of the radiridges, and there's really practically no dermis left. And as you can see, there are some eccrine glands left down in the subcutaneous fat, but those eccrine sweat glands are extremely close to the epidermis. You essentially have no dermis here. The differential diagnoses of acrodermatitis chronica atrophicaans includes a wide variety of peripheral vascular diseases. I've put in malignancy also because in far advanced cases, many of these individuals lose weight. They lose weight profoundly, and they tend to develop a lymphadenopathy, a general lymphadenopathy. And one is forced, I think, to consider malignancy in some of these individuals, at least in your differential. There are no large studies at all of therapy of ACA. Naturally, it's a relatively rare disease. There's only been about 4 or 5 cases in this country in the past 10 years. So I will offer you a suggestion of the method of Eva Asbring, who's a known authority in this field. And Dr. Asbring does use doxycycline for 3 weeks, or phenoxypenicillin 3 grams daily times 3 weeks. For very chronic diseases, especially with nervous and skeletal system complications, she does use benzylpenicillin for 2 weeks, and this is followed by doxycycline. I mentioned that this disease has been known for a long time, even in the United States, and I show you this picture. This is a picture that appeared in the Journal of Cutaneous Diseases, and the date is 1895. And this is a German immigrant who presented to a doctor by the name of Edward Everett Bronson in New York. And I think it's probably the first recorded case of ACA in the United States. Dr. Bronson, if you read this marvelous article, did describe both stages of disease here in acrodermatitis, but of course, he never got much credit for it. The Germans came along 7 years later, and well, he didn't get any credit at all, I guess. This shows some of the wrinkling, a close-up of this photograph, and you can see some of the erosions, the ulcers over the weight-bearing surfaces of the knees. And I wanted to show you some of the varicosities, how grotesque they become when it's superimposed upon an atrophic epidermis and dermis. Thank you for your cooperation.
Thank you very much. The last presentation in this session is by Dr. Smithson he and Dr. Vanderhoof from Research Laboratory at Lockheed Palo Alto Research Laboratory and New York University Stern School of Business, and they're going to speak with us regarding symptoms and characteristics of chronic Lyme disease in patients.
What about this? Yes, thank you. Going to talk about the Society of Actuaries Lyme Disease Foundation database. This was started about 5 years ago, partially funded by the Society of Actuaries. The intent was to build a very large database, as large as possible, encompassing many different characteristics of Lyme disease patients, not only the age and sex and geographical location, but also a wide variety of symptoms and some information on treatment. That database is available to qualified researchers who are willing to share their own data so that we can eventually build a much larger cooperative database. I'm going to try and do this in a very few minutes in 3 different pieces. Summarize where we came from, where we have gotten to prior to today, what additional information I can provide today which will further validate the earlier conclusions, and finally a couple of interesting sidelights on it. Then I'll turn it over to Dr. Smithson for a different approach toward the use of this kind of data in Lyme disease. First, when this was originally presented 2 years ago, we were interested in 2 things. One was the cost of Lyme disease to society. That eventually resulted in an article which was published in a magazine called Contingencies, and the conclusion was that each case of Lyme disease seemed to cost around $60,000, including loss of wages, medical expenses, and everything else, and that the total cost was on the order of $1 billion a year. That's a very soft figure. Maybe $1 billion a year means somewhere between 500 million and $1 billion and $1.5 billion, but still it's a very large figure, even if it's soft. Secondly, by setting up patterns of symptoms, we were able to show that the diagnostic characteristics were not terribly important. The same pattern of symptoms was observed for people who had no EM, no recollection of a tick, and all negative blood tests. The same pattern of symptoms was observed for those people as for the people who were the number of courses of treatment of these 211 cases that responded to our follow-up. You'll notice that the cases who are now symptom-free, they became symptom-free relatively early in their courses of treatment. You can figure that each time the number goes down, it's because there was no further course of treatment. People who are going to become symptom-free seem to do so rather early. Here's the final set of treatments of the portion of this group, the 40 people who are now report to be symptom-free out of the 200 responses. The antibiotics, they had a variety of antibiotics for their last course of treatment. I was looking when I did this for something that would suddenly stick out and say, this is the one. Nothing sticks out. You will notice, however, that the average number of months between infection and diagnosis is down to 5 months for the people on oral antibiotics who are cured. This 60, there was one who was 60 months, so it sort of says that even people who are treated 5 years after infection, sometimes they get better, but mostly it says that early treatment is the only thing which is a dependable guarantee of success of treatment. Here's a list of the different final treatments for the people who are still ill. They tried just about everything. You'll notice also the people who are still ill, on the average, They were about 2 years between the time they were infected and the time they were diagnosed. Early treatment, again, seems to be the only thing that matters. And finally, I have some material here on insurance companies. Some of you are interested in whether insurance companies pay claims or not. I have a list here of companies that didn't pay claims. It's about, this is the list of companies I've got a list of about 170 companies that paid their obligations. I've got a list of about 30 that didn't. The only thing I can tell you about it is that the commercial companies seem to be better about paying claims than the Blue Cross in the United States. These are the companies that didn't pay. You will notice there's a high proportion of Blue Cross Blue Shield plans. I can only suggest that if you're dealing with a commercial insurer and you fight with them a lot, they'll probably pay. But the Blue Cross simply won't. What I've tried to get across in this discussion today is simply that the information we have on the swelling of the joints would seem to validate the information that had been presented at previous conferences, and that, again, the one thing that seems to matter is rapidity of treatment.
What I'm going to do is give you some detail on the results of the study that I introduced at the poster session, and I have a couple of cautionary notes. What we did is we looked to see if there was a way of identifying symptoms or symptom complexes that would be indicative of a cure without permanent damage versus patients that did suffer permanent damage. Cautionary note number one is this relies on the patient's statement that they have been cured. We have no real way of telling whether there was a bacteriological cure involved or not. The statistical results are from a relatively small sample, and therefore we've included error estimates in our accuracy where we can. I caution you that, as you're well aware, if you get results from even a sample of 127, they can be quite suspect in terms of their statistical accuracy. We did not take the treatment regimen used by individual patients into account. That will be done later. And finally, the primary motivation for what we were doing was to see whether these nonlinear, non-parametric statistical techniques could be useful with dealing with this type of data, which is why we picked this particular problem, is for its tractability, not so much for its intrinsic interest, although we believe it has both. Well, if you give a physicist a bunch of sloppy data, the first thing he does is do a scatter plot of it, and that can be quite interesting. What this is a plot of the average frequency or severity on a scale of 0 to 5. On the bottom scale there are people that suffered permanent damage, and on the scale here, the ones that suffered no symptoms after their cure. The diagonal line is the line at which the average severity or frequency is the same for both groups. Now, the first thing that you notice in looking at this is that all of the points for the different organ systems fall on the right-hand side of the line, which means that the sicker the patient is, the more likely they are to suffer permanent damage. Not too surprising. There's one noticeable different exception to that, which is this one right here, which is, guess what, erythema migrans. The more severe it is, the less likely you are to suffer permanent damage, and we, of course, immediately suspected that the reason for that is that it's recognized as Lyme disease early and treated early, and indeed that's true. These patients are treated on the average several months earlier than the ones who don't have the erythema migrans, so we believe that's the explanation for it. Another interesting thing is that for this group of patients who believe they have been cured, these two items up here stand out as being by far the most severe. Now remember, this is a scale of 0 to 5, and it's greater than 4 for those who suffered permanent damage and greater than 3 for those who didn't. Those are pretty sick people on the average. And what is it? Profound exhaustion. For these people, at least, Lyme disease looks a lot more like chronic fatigue syndrome than anything else. That's the single most severe symptom. Now, another thing you might notice is that the ones that are the furthest from the line, which are the ones that are likely to be the most useful in differentiating between the two groups, tend to fall into one of three groups: musculoskeletal, which are the red triangles, eye and ear, and neurological. And we labeled the dozen or so that are the furthest from the line in angular space, and you can see something else. We have, you have frequency, 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 severity, frequency, severity, frequency, 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 severity, and frequency. The frequency or the continuousness of a particular manifestation is a far better indicator of the likelihood of suffering severe damage or permanent damage than the severity. Again, this makes a certain amount of intuitive sense. If something's coming and going, it's likely that it's not permanent, at least at that point, and can be cured. If it's continuous, it may well be the result of permanent damage. So if you have a patient that has continuous, unremitting symptoms, it's probably a good indication that permanent damage has occurred. So, just to summarize the scatter plot analysis, the sicker they are, the more likely to have permanent damage. Only exception is EM. Frequency is more important. Profound exhaustion. The best indicators: frequent neurological, musculoskeletal, and eye-ear symptoms. Now we move on to the nonlinear statistical analysis. One of the things you can do with this is you can start with all 111 different parameters we have. That's 55 different manifestations ranked for severity and frequency, plus the amount of time between infection and diagnosis. Those were the 111 parameters we used. And what our programs do is they do a statistical test on it, a nonlinear statistical test, to determine which ones are the most significant in making that differentiation, and this is the list it came up with, only 7. Now, I have to caution everybody, don't take this as gospel, because depending on the method that you use, you can get this 7 or you can get others and so on, but this one came up with all our different methods, and they're at least indicative of the type of things you look for. And what do we have? Again, mostly frequency. Months between infection and diagnosis was the single best separator. Joint pain, neck and back pain. Why that and something else, I don't really know. But again, frequency, Bell's palsy, cognitive changes. And heart block, myocarditis severity, in this case, was a good indicator of permanent damage. May make a little sense. I'm a layman on this sort of thing, but if somebody has a severe heart condition, the chances are, and maybe even one occurrence of that might cause permanent damage, I don't know. And severity and difficulty of speech. But again, you see the CNS and the musculoskeletal. The other thing that we did was we used similar techniques to develop some symptom complexes that showed similar patterns. Now, here I have to digress just a little bit and talk about what these nonlinear techniques really do. Humans generally reason in at most 2 to 3 dimensions. If you can imagine something that is a 5 or 7-dimensional spiral, you probably can't imagine it, first of all, but such things do exist. There are correlations that can be used to separate things, and the way you try to understand things like that is you do shadow plots. You project these higher dimensions onto a flat surface so you can see what the shadow looks like. And that's what we're doing here. And we're looking at shadow patterns to see symptoms that show substantially the same pattern as other symptoms, and then we're grouping them into complexes. This was done strictly on a statistical basis with no intention of trying to group symptoms by medical category or anything else. The EM showed its own pattern, unique. We had a couple of them. Those top things are just our little tags because they did seem to correspond to certain things. You had heart attack and heart block myocarditis showed about the same type of statistical pattern. Weight loss and TMJ, jaw chewing pain frequency, seem to show about the same pattern. Meningitis and Bell's palsy. And we go on, there are 11 of these, and that's the first 4. Here are 4 others. others, it's possible for a single symptom, because they're being projected into two-dimensional space, to appear in more than one group. We're looking again at unique statistical patterns, and that's kind of the way we split them up. Now, once you take a look at these symptom complexes, you can then analyze those to see methods for doing the discrimination. The thing you look for here is consistency. If you get the same general results for all of them and reasonable error bars, then you start believing that you're looking at real statistically valid data, and as you can see, we've got very good statistics. Overall accuracy, about 80%. By the way, that's not what's in the abstract, and the reason for that is the abstract was written before we had a chance to finish this analysis, so we gave you the center point where it was at that point. It moved down a little. It's now at 80, but plus or minus 10%. You'll notice also that it's easier to predict people who will recover with no symptoms than it is to predict people who have permanent damage. The accuracy with the no symptoms people was in the high 80s, and it was in the high to mid 70s for permanent damage. So if you use this technique and tell somebody they're not going to get well, you're more likely to be wrong. Now, the neural networks reduced the parameter set to 34, and we ran conventional statistics for comparison on that. These can be compared directly to the neural network things above because they didn't really use all 111 parameters. They just started out with that, started throwing them out, and ended up with 34. So then we ran the conventional statistics on the 34, and as you can see, conventional statistics gets somewhere in the neighborhood of 70, a little under 70%, which is substantially lower than what we get with the nonlinear analysis. What does that say? That says there's some hyperdimensional, high-dimensional correlations that the linear and quadratic statistics are not taking into account. We also ran conventional statistics on the 11 complexes. Again, this is what you'd get on the complexes with the unconventional methods. And this one is just a little bit better than this. It's running in the mid-70s. This one we believe is anomalous, and so I wouldn't take it too seriously. This is a linear discriminant. A quadratic discriminant is it's conventional statistics somewhere in between that allows things to do better than a linear, but not much better. And the reason we're suspicious of this one is that zero right over there, plus the fact it's the only one that got all the permanent, essentially all the permanent damages right. We believe that's a sampling artifact. We did not have time to verify that before this talk. We will verify it before we publish the results. The conclusions is, first of all, you can get overall accuracies of 80% or better in predicting Lyme patient prognosis with nonlinear statistical techniques, and linear statistics are a little bit poor. I already mentioned no residual symptoms is more likely to be accurate in prediction of permanent damage. Again, frequent neurological and arthritic symptoms are the best predictors. The EM rash, again, being the only anti-correlated one. This last one I wanted to take a moment to talk about. It's an interesting anecdote in the analysis, but may be very significant. When we first got the data, the form has a scale of 0 to 4. And you notice I said there was a scale of 0 to 5. Well, that puzzled us, so we called the Lyme Foundation and said, how come? And it turned out that the reason was when the forms were entered into the computer, the 0 to 4 was translated to 1 to 5, and 0 was used for did not state. In other words, these are things where the answer to the question wasn't filled out. Well, okay, somebody didn't state it. It probably means they didn't have it, so we'll just change all the zeros to ones. When we did that, we got over a 10% drop in accuracy in discrimination. So we said, well, that's strange, and we changed the ones back to zeros. The accuracy went back up, and not only that, but we found out the people who had lots of zeros were 100% recovers without permanent damage. In other words, if they had zeros, they didn't have damage. So we called Lyme Foundation again. I talked to Tom Forster and said, hey, how about pulling out the original forms, and take a look and see if there's any way you can figure out there's something special. Well, every single one of those individuals had a note that they'd handwritten in the margin somewhere that said something like, hey, I was lucky. I don't have any problem at all. I'm not going to bother filling out the stupid form, basically what it said. Now, I was a patient of Paul Lavoie's. I got on at least 5 occasions a lecture from Paul Lavoie that went something like this. I'd go in and I'd say, well, Paul, I'm feeling pretty good today. I'm going to give myself a 0. And he'd say, pretty good? I'd say, yeah. He said, little twinge now and then? Well, yeah, but, hardly noticed it. That's a 1. His point was that if there were any residual symptoms that were perceptible to the patient, it wasn't symptom-free. And he told me, this has nothing to do with this study, he told me that those patients that he treated to the point where they had absolute zeros, he had got less than a 10% relapse rate on. And if he didn't do that, he got upwards of 60% relapse rate. This is somewhat of a verification of that if you just go out on a limb with me a little bit and say that the zeros are absolute zeros, and the ones are people who were going down, meticulously filling out all the form because they weren't sure whether they really had this or not. It's an indication that one of the better predictors of recovery without permanent damage is absolute cessation of symptoms. So that's the conclusions of the study thus far. Thank you.
Thank you very much, Dr. Smithson. We have time for 2 quick questions for Drs. Smithson and Vanderhoof, if anyone has those. If not, I think we would like to thank all of the speakers in this session. And
so if I could have the overhead first, please. What I'd like to talk to you is really give you some perspective notions about antibiotic resistance. As you are probably fully aware, there are enormous problems in clinical treatment of a variety of bacterial diseases at the present time because of problems of antibiotic resistance. And I'd like to sort of bring up some perspective notions about spirochetes, and in particular Lyme disease. Now, the problem with antibiotic resistance studies at the present time is that they're always retrospective. We don't do anything until somebody comes down with an antibiotic resistant infection. And part of the problem is that there isn't enough education about the fact that bugs do very, very easily become resistant to antibiotics. So what I'm going to talk about today is very briefly to tell you something about what I see as a prospective analysis of potential therapeutic problems. I want to talk to you about gene transfer systems, since antibiotic resistance is very, very important in this area. And if one is going to understand the pathogenicity of Borrelia or any other spirochete, then it's essential that good gene transfer systems and good genetic systems be developed. And finally, I won't go into this in any detail, is the question of the use of mutations as genetic markers so that one can have specific mutations that would permit one to identify particular genes or even particular strains. So could I have the first slide, please? The current status with respect to antibiotic resistance can be summarized in this slide. This is a biochemical demonstration of resistance. The outer white line illustrates the borders of a cell, and this can be any cell you like. And what we need in order for an antimicrobial agent to work, or even an anti-tumor agent to work, is that it enters the cell, as you see on the left-hand side. And there are often specific influx systems, or there may be generalized influx systems. And one of the mechanisms of resistance is that these influx systems can be defective, or these influx systems can be changed. After the antibiotic gets into the cell cytoplasm, there's the possibility of efflux, as shown down on the bottom here. And efflux systems are becoming more and more important. And if I was to bet what will be the first mechanism of resistance in spirochetes, it's going to be increased efflux. Now, I'm not going to put any money on this, but I will bet on it. Now, once the drug has got past this particular point, the drug may be sequestered, it may be detoxified by some mechanism or another, it may require activation. But the drug must finally reach the target. The target may be damaged, and this may be repaired, or the target may be inhibited, and this is, of course, what one wants with a drug. If the target is deleted, removed, if the target is modified, or if the target can be amplified, then you get resistance. So there are many, many ways by which microbes have devised the mechanisms for developing resistance to antibiotics. And as I mentioned earlier, one of the most important mechanisms that we understand now, and which is very, very general, is the question of efflux. And it seems that all cells have very adaptable efflux systems that can be used for a variety of different drugs. Tumor cells can efflux anti-tumor agents and so on and so forth, and this is true for many different antibiotics. So this would be my bet for spirochetes. The situation with respect to most bacteria, and this does not include spirochetes because we have a very poor understanding of antibiotic resistance in spirochetes at the present time, is that there is an environmental gene pool which can be accessed by any organism. The organism accesses the environmental gene pool by taking up resistance genes from this environmental gene pool, incorporating them into replicating systems, and then using these replicating systems to propagate the antibiotic resistance gene within the organism and within related organisms. And one very important aspect about antimicrobial resistance that I'm sure you're aware of is the fact that antibiotic resistance can be spread. It can be spread by gene transfer mechanisms between a variety of different organisms. So that gene transfer mechanisms permit the transfer of antibiotic resistance between plants, simple bacteria, yeast, gram-positive, gram-negative, mycobacteria. It doesn't matter what kind of bacteria, with one exception, and I will come back to that in a few moments. But gene transfer systems are capable of disseminating resistance genes throughout the microbial kingdom, and as you see here, also even into plants. So that's the situation that we face, and the question one has to ask, is this the kind of situation that one will find with spirochetes? I think this is unlikely at the present time. On the other hand, it is not worthwhile trying to advocate any form of complacency, because it is likely that mechanisms of resistance will eventually develop because of the use of antibiotics. Now, could I have the transparency? Slide off, please. Now, I mentioned earlier there are a variety of different resistance mechanisms that occur in cells. Some of them, in some cases, you may have just one resistance mechanism. In many cases, there could be more than one. And what I want to point out is here are the biochemical mechanisms. I've given you some examples which are with typical microbes, with typical antibiotics. And what is understood at the present time is that these resistance mechanisms can be generated either by mutation in the microbial host or by acquisition. And there's a very large number of resistance mechanisms that can be acquired by acquisition from a gene pool or from outer space or from somewhere. But the bugs get the genes from somewhere and they become resistant. Now, what will happen with treponemes, I can't really say. The point is that there is no doubt at the present time that overuse, imprudent use of antimicrobial agents leads to the development of resistance, either by mutation or by acquisition. Now, let me move to another point. Can I have the next transparency, please? And that concerns the question of using antibiotics and antibiotic resistance for genetic engineering. And I'm saying this with the full knowledge that we need good genetic engineering systems for spirochetes. As I mentioned earlier, if we want to understand pathogenesis mechanisms, we've got to understand the genes for those pathogenesis mechanisms. And in order to have a genetic system based on genetic engineering, one has to have selective markers. And we have available a whole series of selective markers for use in microbes and in eukaryotes. So this indicates either prokaryotes or eukaryotes. There are a whole series of selective markers which are different inhibitors used in combination with different antibiotic resistance genes. And these combinations are used in order to create vectors that can be used for transferring genes within and between different types of organisms. And one desperately needs this type of system in spirochetes at the present time. There are resistance genes, but they are no good as resistance markers. They are not selective markers for vectors. There's some nice work from the Rocky Mountain Laboratory demonstrating coumadin resistance, but unless one can get dominant resistance, that is, the gene for resistance must be dominant over sensitivity, then the system doesn't work as a selective marker, and this is something that is needed. Sorry, next transparency, please. Now, the considerations that one wants to make in using a selective marker is obviously whether or not the host you want to study is sensitive to the antibiotic you want to use. And in that particular case, one is saying, is a treponeme, is a spirochete, is a particular microbe sensitive to a particular inhibitor? And that's the essential starting point. The next 3 points consider, B, C, and D, concern one with whether or not the resistance gene is expressed in that particular host. Now, Borrelia is a very interesting situation. Borrelia has a very, very high AT content. It has a very, very high content of adenosine and thymine in its DNA. This creates certain restraints on the ability of genes to be expressed in terms of transcription, that is making messenger RNA, or in terms of translation, or in terms of codon usage. What codons are responsible for determining what particular amino acid? So one has a problem in Borrelia due to high AT content. The other problem that one has is that sometimes the expression of a resistance gene in a host is deleterious to the host. The best example of that is tetracycline resistance. In many microbes, the expression of tetracycline resistance actually affects the growth of the microbe. So I will make a prediction here. If one wants to develop good genetic systems for Borrelia, where would we start? I would suggest that we start with what is known in Clostridia. There have been a lot of studies with Clostridia. Genetic engineering in Clostridia is now commonplace. Clostridia are high AT-rich organisms. There are vectors, there are resistance genes, and there are transfer systems that have been developed. So I would suggest if one wants to get really good systems to work in Borrelia, then one should really study the literature in the case of Clostridia, because I think there are some good guide points there. If I was going to start working on Borrelia tomorrow, and I won't, unless somebody gives me $1 million grant, then I would start working on Clostridia and use the Clostridial systems. Can I have the last overhead, please? Or the next to last? No, this is the last overhead. The problem that one faces, whether one is talking about antibiotic usage or whether one is talking about the development of genetic systems, is that the spirochetes come in a funny place in terms of the phylogeny of bacteria. I'm sure you're aware of this. One has the gram-positive bacteria as a group in the bottom. One has cyanobacteria and archaebacteria as a group at the top. One has the gram-negatives, the eubacteria in the middle, and then just below that, and then one has the spirochetes right in the middle, related to a variety of sort of oddball organisms. But they're not oddball organisms. They're very interesting organisms. They're very, very old organisms. And they're the organisms that one needs a lot more work on. And I think there are ways that we can do this, and I would be happy to discuss them with you. Thank you very much.
From New York Medical College, our next speaker is Dr. Ken Ligner.
I want to thank the BC Borreliosis Society and the LDF for inviting me to this conference. I have to tell you that I'm positively euphoric to be in Vancouver, and I wish I could stay for 10 days or maybe for 10 years. I asked Martina a couple of weeks ago whether it might be possible for me to extend my talk to 1 hour, and she said no, just like everybody else, 15 minutes. So this is going to be very kind of clipped and almost like sound bites. I have 4 interesting cases, and I'd like to try to cover them. And the timer person up in the front, could you do me a favor? Could you, at 5 minutes, 10 minutes, and 10 minutes, let me know, just so I can try to pace myself. Okay, wait a second. Is this back at 0? Is this at the... I guess so. Okay, the first case that I want to discuss was the case of the person in the videotape yesterday who's Vicki Logan, and that's not a secret because her case is part of public record. She was in the New York Times. Let me just try to give you a very brief overview of her case. She developed a neurologic illness manifested by gait disturbance and cranial nerve dysfunction. She was very fully evaluated by many people, including some very, very fine neurologists. In fact, one of the neurologists probably might be considered one of the deans of American neurology at the present time. She got a variety of recommendations and diagnoses, including that she had a psychosomatic illness, and that dean of American neurology told her, you really ought to stop pursuing a diagnosis and just accept, your illness. She came under my care, and it was quite a long period of time where I did not know what her diagnosis was, despite very intensive study. She was admitted to hospital, had a spinal tap. We did every test that we could possibly think of. She had a pleocytosis in her spinal fluid for several years that was unexplained. We naturally did all kinds of tests for HIV and tropical spastic paraparesis and whatever you can possibly think of, and Lyme tests, and everything was negative. And finally, because we could think of no treatable diagnosis other than Lyme, and she had lived in a Lyme endemic area, we decided to treat her. We treated her with 21 days of cefotaxime, did spinal taps both before and after treatment, and there was really no difference on her spinal fluid parameters or her clinical status. Nonetheless, I opted to treat her for 4 months after that with minocycline, and again, there weren't really, it was pretty meager results, so I stopped treating her because it wasn't clear that she had Lyme disease. And then about, 6 or 8 months later, she was continuing to deteriorate. She was hypersomnolent, sleeping like 18 hours a day. She begged me to have another spinal tap. And at that time, fortuitously, I was collaborating with the CDC. I had BSK culture media, and this was December of 1991 that we tapped her and cultured. And a couple of weeks later, I got a very excited call back from Dave Dennis that they had isolated, they had found spirochetes in her spinal fluid. And he also asked me whether I kept any spirochetes in culture in my office, and I said no. This is the actual report with a handwritten note from Roy Campbell saying that the identity of B. burgdorferi had been confirmed by PCR. Once we had the diagnosis, I knew that 3 weeks of daily cefotaxime didn't work, and I was aware of Priyak Mersik's article, Hassler and Priyak Mersik's article on pulse cefotaxime, so I decided to employ pulse cefotaxime, and with that, after some 13 weeks of pulse cefotaxime, I repeated her spinal tap, and the pleocytosis had completely resolved. And she also had some modest improvement in her status. In this case, and also the other cases, I did not make tables, partly because I guess I really didn't have the time to make tables, and also I wanted to present you with the actual documentary evidence in this case and the other cases, partly partly so that you know that I'm not making these things up. These things really happened in my patients. Okay, this was her TAP in December of 1991. I would point out to you that there was absolutely, positively no serologic evidence of Lyme disease up until this point, where the specimen that we were able to isolate the Borrelia, she also, by that time, had seroconverted and did have selective intrathecal antibody synthesis. This is her serum pair, and this is her CSF pair. Okay. I also wanted to show you what her CSF parameters looked like at that time, and I don't know if the people in the back can see very well, but she did not have either oligoclonal bands or myelin basic protein. I want to point out the elevated CSF IgG and also the elevated IgG synthesis rate, which I have found in many of my other patients with serious neurologic disease. I'm going to have to really speed this up. Okay, I also want to point out that she had a Western blot that, although it showed a lot of bands, and they said it was sort of consistent with the ELISA, there were no bands here that were reported as specific. And I want to point that out because that at the time this patient was culture positive, she really didn't have, I don't think, a fully diagnostic Western blot. Okay, she got treated with, let me just go back, no, sorry. She got treated with 13 weeks of cefotaxime in a pulse regimen. She was retapped, had again elevated cells in her spinal fluid, wasn't really doing that well. Spasticity was a great clinical problem, and I sent her out to a tertiary medical center for consideration of a baclofen pump. There she came under the care of the rheumatologists, who were kind of dubious of the treatment that she'd received, but just for good measure, they treated her with 2 more weeks of ceftriaxone just to be sure that they could eradicate any Borrelia, and felt that she must have a lupus-like syndrome, and treated her with high-dose pulse solumedrol, followed by a long high-dose taper. During that time, she developed pleuropericardial effusions, and this is a CAT scan after she had returned to my hospital with a significant pleuropericardial effusion. She was, at this time, very, very, very sick, remarkably encephalopathic, so that if you would talk to her 10 seconds, 15 seconds after you would talk to her, she would have no recollection of what you were saying. A lot of my colleagues at the hospital felt that she was surely going to die, and it was felt important that we not be missing some other treatable diagnosis. So partly for therapeutic, but mostly for diagnostic purposes, a pleuropericardial window was performed. That tissue eventually was sent to Paul DeRay, who was able to identify on silver staining spirochete compatible structures. And again, this is the documentary evidence. This was the H&E of her pericardium, which showed an infiltrate of mononuclear cells and plasma cells and a bunch of other types of cells. This is a modified Dieterle stain, which I think you can see a spirochetal structure or spirochete compatible structure. This is a gram stain that Paul DeRay made, and I think you can see a very nice spirochete there. And this is a phycoerythrin stain with polyclonal antibodies against Borrelia. This is before I had any of this information back, by the way. I decided to hell with it and just to treat her, and I treated her with cefotaxime for several months. After several months of treatment, her CT scan, which I think is at about the same level, looked like this. She became very, very improved clinically from someone who could barely hold a cup or roll over in bed or transfer to being able to walk 500 feet with a walker. Her mental status, although not normal, was much improved, and one could have a fairly normal conversation with her. She was discharged from hospital, kept on IV antibiotics for another couple of months until her insurer finally said they would not pay for any further intravenous antibiotics. At that point, she was actually doing relatively well clinically, so we said, okay, we'll go with it. We suspended any treatment, and then about 6 months later, we admitted her to hospital for consideration of a baclofen pump. That was not able to be done because of a prolonged bleeding time. I just want to show you some further serologic testing that was done, including, this is June of '94. Western blot was
was rather nonspecific and would not be considered a diagnostic Western blot. This is in February of '95. We have a Western blot that is, again, not a particularly diagnostic Western blot. And a reactive ELISA. And here we are in February of '95. She'd gotten a lot of other treatment in between. In fact, we did treat her with several months of IV antibiotics again, and did serial neuropsych testing through Brian Fallon's research project, which was able to document improvement with treatment. And here she is after many, many courses of prolonged and intensive intravenous antibiotics, PCR positive. This is in peripheral blood. I'll have to turn you over to Dick Tilton to ask him what degree of confidence he has that this positive PCR is meaningful. She happened at this time to be on prednisone, I guess, on prednisone for ITP. It's a very long and complicated story, but clinically, this patient behaves as though she has chronic persisting infection. We have laboratory documentation of it, and I really don't see a whole lot of alternative to her besides continuing to treat her in some fashion. Okay.